this is the external branch of the superior-laryngeal nerve which needs to be protected while ligating the superior thyroid pedicle. And this is a thyroid bed. After doing a total thyroidectomy, you can see the both sides recurrent laryngeal nerve and the parathyroid glands which are saved at the end of the thyroid surgery. Another concept that we have propounded is do a compartment dissection for medullary thyroid cancer. So here we have done a central compartment dissection and bilateral modified neck dissection. So this is a kind of extensive surgery because there is no good adjuvant treatment for medullary thyroid cancers. Again, for a differentiated thyroid cancer, this is the central compartment. You can see the nodes, and this is case of papillary thyroid cancers where there is a recurrent laryngeal nerve and an entire central compartment is dissected. We also have propounded the prophylactic thyroidectomy in patients who have a genetic mutation, and this is a patient who had codon 634 mutation which was positive, and this was a family of 3 siblings where we performed prophylactic thyroidectomy once the genetic mutation was detected. We also perform endoscopic and video-assisted thyroidectomies for patients with small thyroid nodules less than 4 centimeters. Another concept in safe thyroid surgery is use of neuromonitoring, where we, with the help of electric current, we signal the nerve, and we know that the particular structure is a recurrent laryngeal nerve, and we can save it and protect it. Latest technology is now being integrated into the surgical operation theaters, and instead of the conventional knot and tying, we can use the harmonic or the electric cautery, bipolar cautery as well. To do the entire surgery is actually sutureless, and not a single suture is used while doing a thyroidectomy skin to skin. Now moving on to parathyroid glands after the thyroid surgery. This is a typical parathyroid patient, as Akhil was mentioning. We get young patients with multiple fractures, very severe osteoporotic bones. And our initial strategy was to perform a bilateral exploration by a long incision which is around 6 to 8 centimeters. But we have pioneered this is a patient where 3.5 gland parathyroidectomy was done, and along with the thymectomy. This was a patient of familial parathyroid disease. But now, because of the advent of a very specific parathyroid scan, which is a MEB scan, which actually localizes the parathyroid gland in the neck, one can do a focused parathyroidectomy. So this is a MEB scan, and this is the parathyroid adenoma in the neck. And we perform an intraoperative ultrasound in the operation theatre, and then do a focused parathyroidectomy. That is, we remove the parathyroid gland with a very small incision which measures 1.5 to 2 centimeters. So instead of a long incision, we give a small incision. But things have changed again, and we now perform an endoscopic parathyroidectomy where there is no incision in the neck, and we go by the breast approach, put an endoscope here and remove the parathyroid gland. So in young patients, it's a boon for them because cosmetically the neck is virgin and there is no incision in the neck. We perform an intraoperative PTH assay where we know there's a drop. For example, this patient had a preoperative level of 528 parathyroid hormone level, which actually drops down in 10 minutes to 29, and so this is suggestive of cure in a patient. So intraoperative is very reassuring to the surgeon and to the patient that the patient is actually cured. Katyar has already talked about breast, but just a couple of slides. We do sentinel and lymph node biopsies for breast cancers, and so full axillary dissection can be avoided in patients, and therefore attending morbidities like lymphedema, difficulty in driving, shoulder pains can all be avoided in patients where an axilla is not dissected. And we do breast reconstruction using flaps and silicone implants and neoadjuvant chemotherapy for locally advanced breast cancers. Now the third important disease is Gsvm pheochromocytoma, and I'm sure we all used to skip over our endocrine chapters in Love and Bailey, but I'm stuck with those glands for life. Now pheochromocytoma is not really so uncommon. I've operated more than 200 of these in our institution, and I'll just give you a couple of examples. This is a 7-year-old child who had a bilateral pheochromocytoma, and he was hypertensive in the range of 200 to 160 millimeters of mercury. And this is, I removed a bilateral pheochromocytoma. In fact, he had 3 pheochromocytomas, one on the right side and 2 on the left side. So this is 1 here and 1 here. Another patient with a very large pheochromocytoma, which measured around 18 into 18 centimeters. And this is actually, you can see the adrenal vein, which is as big as the renal vein. And this was actually a 2 kilogram of a pheochromocytoma in this patient. And this is the kind of obese patient which is challenging to remove pheochromocytomas in these patients. And you have to really give a long incision. But things have changed, and what we do is remove the adrenal gland laparoscopically. And here the patient has just 3 small holes from where the gland can be retrieved. I also perform, video-assisted or thoracoscopic thymectomies for patients with myasthenia gravis. And we have the help of very competent department of anesthesia. You can see a double lumen tube here in order to have a single lung ventilation in a patient who is undergoing thymectomy. And here a thymectomy has been done through 3 small holes instead of doing a sternal split. So cosmetically the patients have a better outcome, and they're usually pain-free following surgery and can be discharged usually on the second post-operative day instead of a stay of 10 days in the hospital. And this is a specimen of the thymus gland removed thoracoscopically. Also perform laparoscopic enucleations of pancreatic insulinomas, and this is a young child, I think he was 18, where we use...
Thank you, Dr. Agarwal. Now I request Dr. Ritu Budhwar to give Dr. Agarwal memento and certificate. And I invite Dr. Pankaj Srivastava to please come up on the stage and help in chairing the session. Pankaj Srivastava, sorry. To please come and give the next talk.
Aruna is the director of Central Florida Sleep Institute in Lake Mary, Florida, United States. She will be talking about obstructive sleep apnea.
Everybody, thanks for being here. I'm going to talk briefly about obstructive sleep apnea, which is a very commonly ignored and underdiagnosed disorder. Now, I want you to raise hands who snore at night. Okay. I want to make a comment. If your spouse complains of disturbing, loud snoring that makes you leave the room, please get yourself tested and have a sleep study done to rule out obstructive sleep apnea. Okay. Then you should earplugs लगा के सोया करो फिर. Okay, I'm going to move forward, please. Okay, how do we make a diagnosis of sleep apnea? As I said, the main symptom is snoring, restless sleep pattern, fatigue, tiredness. Patients who have very large neck circumference, like in men 17 inches and in women 16 inches. Now, it's a myth that sleep apnea only happens in obese individuals. A lot of patients who are average built, if they have a special or specific airway anatomy that's causing them to have retro or micrognathia, the way their tongue is placed, if they have very large voluminous tongue, low set palatal arches, a lot of lateral narrowing, lot of lateral folds that is causing the narrowing of the posterior pharynx will make them predisposed for sleep apnea. Often patients will wake up unrested, unrefreshed, tired, fatigued, lacking energy. At times they wake up literally snorting or making a gasping, choking noise. And spouse, as Sangeeta said, she cannot sleep without that nice snoring of her husband. But if you, Sangeeta, if you notice that he makes, if you notice the pause in his breathing and then he gasps and choke his breath, he must be tested. If your spouse falls asleep watching television, he dozes off, nods off, especially he doesn't want to hear you and you get angry at him. If the patient wakes up with morning headaches, you can have memory loss, loss of concentration. as I was mentioning outside to one of my colleagues, that nocturia is a very important symptom of sleep apnea. You can have sexual dysfunction and low testosterone level because of sleep apnea. Some of the medical conditions that can be associated with sleep apnea are hypothyroidism, acromegaly, amyloidosis, vocal cord abnormalities, Marfan and Down syndrome, and neuromuscular disorders. Usually in neuromuscular disorders, some other type of hypoventilatory sleep disorders happen, not just obstructive sleep apnea pattern. Often at times we rate patients' sleepiness score by a score or scale called Epworth Sleepiness Scale. And if the score is 10 out of possible 24, that indicates excessive sleepiness. This is just the schema, how the sleep apnea happens. So, I'll just read it here. When we sleep, the airway kind of collapses. You have decreased airway patency compensation, airway collapse depending on your airway anatomy. Your blood oxygen level saturation drops, you develop hypoxia, you develop hypercapnia, you reach a threshold, and then you take a deep breath and you break that apnea and you have hyperapnea episode. You have an arousal in the brain, and then you wake up and break that cycle. So this cycle goes on all night long. Why is it not moving forward? One out of every 4 men has obstructive sleep apnea, and 1 out of every 6 premenopausal women has obstructive sleep apnea. The incidence is about the same in postmenopausal. Now, a lot of consequences that can happen if sleep apnea goes untreated. The medical long-term consequences are real. The data is so strong with hypertension, heart disease, ischemic heart disease, heart attacks, atrial fibrillation, mini strokes, which we call TIAs, and even strokes. And you develop impaired glucose tolerance. Because of the excessive sleepiness, a lot of motor vehicle accidents also happen. You can have neurocognitive and performance deficits. So more than 40% of patients who have obstructive sleep apnea have daytime hypertension. And 30 to 50% patients with hypertension will have obstructive sleep apnea. So even mild obstructive sleep apnea is a risk factor for hypertension. So please get yourself tested. If you have a patient who has been resistant to have adequately treated for hypertension, think of sleep apnea. If you have a younger patient with new onset,
and Dr. Ritu to please present memento and a certificate to her. I invite the next speaker, Dr. Anil Kumar Mishra, to please come up on the stage.
Dr. Anil Kumar Mishra. Currently, he is the General Manager and Head, National Disease Control Program Division, State Program Management Unit, Government of Uttar Pradesh, India. He has a job responsibility of planning, financing, and monitoring. He's got a postgraduate gold medal from KGMC Lucknow. Dr. Stage lights, please. Stage lights. Dr. Wadhwa Memorial Gold Medal KGMC Lucknow, and he has been awarded fellowships by the WHO to study field epidemiology in National Institute of Communicable Diseases India, and again fellowship awarded by WHO to study prevention and control of Japanese encephalitis, Thailand. Dr. Anil, please go ahead.
Good afternoon. I thank the organizing committee and the chair for giving me this chance to have a discussion on public health issues. Here, I think the topmost international surgeons deliver their research work before us, and I'm going to talk on the topic which is most important but rather neglected as we neglect SPM in our undergraduate studies. Dear friends, my topic is NRHM, Improving Healthcare Delivery System. Let us see what is NRHM and how it's improving healthcare delivery system in the state as well as in the national scenario. I'm going to focus its improvement done by the NRHM activities in the state. NRHM is focuses on affordable, accessible, accountable, effective and quality services to the masses, especially to the vulnerable group in the community. It's a bottom-up, decentralized and community-owned approach to public health planning. What was initially done? The planning of the public health was done at the top level, at the directorate level, and the district level and the lower level has to implement what has been planned already at the highest level. But it has been changed. Now the planning is being done at the village level, then it goes to the block level, then it goes to the district level, and then we finalize the whole planning at the state level. Government of India approve the planning, finance it, and as per the planning at the village level and the block level, the implementation is done. This NRHM focuses on two issues, health and health determinants, as we know. And this health issue is RCS, reproductive and child health, as we have already gone through it in RCS 2, and then general curative care, then National Disease Control Program, and further we are having the Ayush system, which is a mainstream of Ayush in allopathic system. This is health determinant, nutrition, sanitation and drinking water supply. And nutrition, we are going to this year have a nutrition mission, other state nutrition mission, and that is a very promising mission from the Chief Minister of the state. This NRHM is having convergence with other departments like ICDS for HLD, with education and this PRI, Rural Development Department, Urban Development Department, because we are having the health department also, which is going to affect the public health, that is the nutrition, sanitation, and your drinking water supply, safe drinking water supply. So we have to coordinate with other departments for giving the health, for approaching towards health for all. This is system of financial flow, because I especially want to focus on what is the financial flow, because we have gone last 2 years, we are reading every day a lot about the NRHM, but what is exactly is the, we see that what is the financial flow and how the finance is going from the government of India to the lowest level. So it will make all the persons, all my colleagues who are here. So if you just monitor the financial flow and follow the guidelines provided to the financial flow and financial how you are going to utilize the budget, then there will be no problem. So this is the government of India approved the PIP as and release a fund in the flagship pool. Funds are state health society